Imagine going to a specialist to fix a really painful, like, decades-old childbirth scar.
Right. You go in hoping for some relief.
Exactly. But then you find out the laser treatment they recommended just turned that tissue into a permanent, completely unbendable stricture.
It's a devastating outcome. What looks like a quiet, closed chapter on the surface is it's often a dormant fault line at the cellular level,
Yeah.
just a structural compromise waiting for the exact right conditions to fracture.
Welcome to today's deep dive. We are tackling one very specific, very urgent question today.
Which is incredibly important for so many people.
It really is. The question is, if you try to surgically fix an old childbirth scar, can you actually ruin the microscopic blood flow and make the dryness and pain permanently worse?
To understand why a surgical revision might not just fail, but actively accelerate a patient's pain, we really have to strip away the macro view.
Right. Look closer.
Yeah, we have to get down into the microscopic world of how human tissue breathes, how it feeds itself, and most importantly, how it just completely panics during an injury.
Okay, let's unpack this. We are pulling our insights today from a really thick stack of clinical guidelines, including those from NICE, the National Institute for Health and Care Excellence, along with advanced physiotherapy manuals and clinical reviews on gynecological scars.
It's a lot of dense material, but it paints a very clear picture.
It does. But before we get to the well-intentioned surgeries that go completely off the rails, we need to establish what healthy healing actually looks like. Or, well, what happens in those chaotic first moments of a childbirth injury.
Right, we have to look at the scale of the trauma first, because childbirth injuries, they range significantly.
Like from minor to severe.
Exactly. You have first-degree tears, which are basically just superficial grazes on the skin of the perineum or labia.
Okay.
Then second-degree tears plunge deeper, right into the perineal muscle itself. Third-degree tears tear into the anal sphincter.
Ouch. Yeah.
And fourth-degree injuries go right through to the bowel lining. Plus, we also have episiotomies, which are, intentional surgical cuts made by a doctor to widen the opening.
And whenever any of those happen, the body's emergency response system just goes into absolute overdrive.
It does. It has to.
It rushes this protein called collagen to the site to patch the hole, but it's not, like, taking its time. It's an evolutionary survival mechanism to stop the bleeding.
Right, and close the barrier against infection.
Yeah, so just kind of dumps the collagen there in a hurry.
Speed is totally prioritized over architecture here. The fibers overlap haphazardly. They cross over one another in this dense, chaotic matrix.
Just a mess of fiber.
Pretty much. And they create that thick, rigid tissue we identify as a scar. And sometimes the body's repair mechanism gets stuck in the on position.
Oh, like it overheals?
Yes, producing what we call granulation tissue. These are bright red, raised patches of raw tissue that bleed at the absolute slightest touch.
That sounds awful.
It feels incredibly raw, almost like a localized burning sensation.
Wait, I have to stop you there. Because the beauty industry sells this collagen as the absolute holy grail for glowing, plump, elastic skin.
No, absolutely.
Like, we're told to drink it, rub it on our faces, inject it. Are you telling me that down here, in the pelvic floor, collagen is actually the villain making things rigid?
What's fascinating here is the difference in how that collagen is woven.
Woven, like a fabric.
Exactly. In healthy, youthful skin, collagen is highly organized. It acts like a perfectly woven, flexible net that just moves with you.
Okay, that makes sense.
But the rushed collagen in scar tissue, it's like a tightly tangled ball of yarn. The body trades all elasticity for a really quick structural patch.
Just to get the wound closed.
Right. And by locking that tissue down so tightly, it actually chokes out something utterly vital for tissue survival.
Which is what?
The microvascular network.
The microscopic blood vessels.
Yes, exactly. In healthy genital tissue, you have this beautiful dynamic process known as vasomotion.
Vasomotion.
Yeah. It involves the intermittent opening and closing of precapillary sphincters.
That's a mouthful.
It is, but just think of them as microscopic floodgates. They open up, allowing oxygen and nutrients to rush into the tissue, and then they flush away metabolites and cellular waste.
So the tissue is essentially breathing and cleaning itself out.
That's exactly it. It expands, it contracts, it maintains its own ecosystem. And the degree of this vasomotion is actually a primary indicator of healthy tissue and sexual arousal.
Right.
But that tangled, rigid mass of scar collagen severely lacks this delicate vascular network.
Because it's too dense.
Yeah, the scar tissue is practically suffocating because it physically cannot support those microscopic floodgates.
Wow. So it's a rigid, poorly oxygenated patch. But here's the thing. I mean, for a lot of people, the initial tear heals.
Right, the surface closes up.
The stitches dissolve, they do their pelvic floor exercises, and they go on living their lives, feeling mostly fine for 5, 10, maybe 20 years.
Which is very common.
So the real mystery here is why a woman who seemed to heal perfectly fine a decade ago suddenly experiences intense, localized dryness, pulling, and agonizing pain in that exact spot later in life.
Well, that delayed reaction all comes down to the endocrine system.
Hormones.
Exactly. The hormonal environment acting on that compromised microcirculation suddenly shifts. Specifically, we are looking at the systemic drop in estrogen.
Which we usually associate with that massive drop during menopause,
Right.
which leads to what clinicians call genitourinary syndrome of menopause, or GSM.
Yes, but it's important to note this estrogen crash also happens during breastfeeding.
Oh, right. So what is estrogen actually doing for this specific tissue before it drops? Like, why is it so important?
Estrogen is essentially the great protector of the pelvic floor. It maintains tissue elasticity. It drives ongoing collagen remodeling so that fibers stay somewhat organized.
Okay.
And crucially, it supports vascularization. It is the literal chemical signal that keeps those microscopic blood vessels open, flexible, and functioning.
So when you lose that systemic estrogen, the whole neighborhood essentially goes into a drought.
A severe drought, yeah.
What does that actually look like for the patient experiencing it?
It's a devastating cascade, honestly. The overall moisture level plummets. You lose vaginal rugae.
And those are the folds, right?
Yes, the natural accordion-like folds that allow the vagina to expand comfortably. You lose those.
Wow.
The tissue becomes incredibly frail, and you even start to see petechiae.
Which are?
They are these tiny, pinpoint bleeding spots right under the surface. Even the urethra can begin to prolapse.
If you're listening right now and you've ever felt that intense pulling sensation years after giving birth and you've just been told like, oh, it's just menopause, this next part is vital.
Very vital.
Because while the entire urodistal tract is starving for blood flow, that old childbirth scar suffers the absolute most.
Because it was already operating at a severe deficit.
Right.
It barely had any microvessels to begin with because of that tangled ball of emergency collagen we talked about.
It's already vulnerable.
Exactly. When the systemic hormonal shift happens, it exposes the underlying structural weakness of the scar. The surrounding tissue is thinning, but the scar itself pulls, it shrinks, and it creates a hypersensitive focal point of extreme mechanical tension.
It's like a drought hitting a city.
That's a good analogy.
The whole city is dry, but the specific neighborhood that already had leaky pipes and terrible infrastructure completely collapses first.
Exactly. And this mechanical tension and the severe lack of lubrication lead directly to dyspareunia.
Severe pain during intercourse.
Yes, as well as pain just from sitting or walking sometimes.
Right.
Which brings us to the pivotal crossroad for so many patients.
Right.
To fix this excruciating focal dryness and pain, patients turn to specialists, and the recommendation is often a surgical revision.
And this is the core question we set out to answer today. If a patient gets a perineoplasty, where they basically cut out the old scar and resuture it, or they undergo transvaginal laser therapy to burn away the bad tissue, can that actually backfire?
That is the big question.
Can it alter the localized microcirculation and create an even worse, persistent mucosal dryness?
The clinical data points to a resounding yes.
A resounding yes.
Yes. These interventions can be entirely counterproductive. Let's examine the transvaginal laser therapy first, like the CO2 or erbium-Y key lasers reviewed in the NICE guidelines.
Okay.
The entire mechanism behind them is controlled thermal injury.
So the idea is that if you intentionally burn the tissue at a microscopic level, you provoke the body into a brand new healing response.
Theory, yes.
You trick it into generating new, healthy collagen and stimulating neovascularization, new blood vessels. I mean, it sounds incredibly logical on paper.
It does. But that thermal trauma relies entirely on the tissue having the metabolic energy and blood flow to mount a healthy repair response.
Oh. And we just established that this specific scar tissue is severely compromised.
It is suffocating.
Yeah.
It physically does not have the blood flow to heal properly from new intensive laser burns.
Here's where it gets really interesting, though, honestly, in a pretty devastating way.
Yeah.
When you hit a starved scar with a thermal laser, you can trigger a total tissue collapse.
The NICE overview details some truly harrowing realities. Take the specific case of a 68-year-old woman suffering from severe vaginal dryness and coital pain.
Okay.
She underwent 3 full courses of this laser treatment, and instead of remodeling into healthy, moist tissue, her body reacted with extreme fibrosis.
Extreme fibrosis. She developed a crescent-shaped fibrous band right in the mid-vagina.
Yeah.
It literally created a partial obstruction, a stricture in the vaginal canal. Her tissue was left pale, completely inelastic, and she had a severe decrease in those natural folds.
Exactly. The treatment meant to stimulate moisture created a permanent avascular desert.
That's so tragic.
It really highlights a fundamental misunderstanding of tissue mechanics. You simply cannot force a highly compromised, poorly oxygenated environment to magically regenerate by subjecting it to extreme thermal trauma.
So what about just cutting it out? If a surgeon performs a perineoplasty, physically removing the old scar and stitching the healthy edges together, isn't that just creating a brand new wound?
It is.
Don't you risk trapping something in that new, tight tissue as it heals?
That is the exact risk specifically concerning nerve entrapment.
Nerves.
Yes. As the new surgical wound heals, it generates a new wave of scar tissue. If the tiny parietal somatic nerves get caught in that dense fibrotic web, they become severely compressed.
And when nerves are compressed, they panic.
They do. They fire constantly.
Yeah.
The result is severe neuropathic pain, often described by patients as a constant burning, tingling, or sudden electric shocks.
That sounds unbearable.
And furthermore, the physical shortening of the tissue from repeated excisions can be disastrous. There's another reported case of a woman who underwent laser therapy, resumed intercourse shortly after, and suffered severe vaginal wall lacerations that actually required surgical repair.
And the aftermath of that repair was unthinkable, right?
It was.
Several months later, her vaginal canal had become foreshortened to just 2.5 centimeters in length due to the dense fibrotic tissue that formed at the apex and within the canal.
Interventions designed to stimulate blood flow and collagen actually burned out whatever fragile microcirculation was left.
It's crazy.
They tipped the tissue over the edge into total fibrotic failure.
The tragic irony here is staggering. By trying to force the tissue to heal through destruction, we permanently ruin the localized microcirculation.
Exactly.
So if cutting out the scar or burning it with a laser creates a fibrotic trap that makes the dryness infinitely worse, what actually works? How do modern specialists safely restore the flow?
Well, the field is rapidly moving away from destruction and toward rehabilitation.
Okay, rehabilitation.
The goal is coaxing the microcirculation back to life without triggering that panic-driven collagen dump.
Let's talk about how they do that, starting with carboxytherapy, because this sounds entirely counterintuitive to me.
I know it does.
They are using microinjections of carbon dioxide gas directly into the starved scar tissue. Why on earth would you inject a waste gas into tissue that is already suffocating?
It exploits a brilliant physiological reflex. When the local tissue detects a sudden, massive spike in CO2, the brain receives an urgent signal that the area is severely deprived of oxygen.
Oh, I see.
So the body's automatic response is to forcefully dilate the surrounding blood vessels.
And the conversion rate is wild.
It really is.
For every 1 unit of carbon dioxide injected, the body is forced to send 20 units of oxygen-rich blood to the area. It forcibly flushes the starved scar tissue, kickstarting that vasomotion, those microscopic floodgates, back into action.
It clears out the built-up metabolic waste and provides the vital raw materials needed for genuine cellular repair.
Okay, so carboxytherapy floods the area with blood and oxygen, but what about that rigid, tangled web of old collagen?
Right, the structure.
Because blood flow alone isn't going to magically entangle that structural mess.
That brings in radiofrequency therapy, specifically utilizing a frequency of 448 kilohertz. Okay, the crucial distinction here is that this is non-ablative. It does not cause destructive thermal injury like the lasers do.
So how does it untangle the collagen without burning it?
This specific frequency triggers cellular biostimulation through increased ion exchange.
Ion exchange.
Yeah, at a cellular level, it helps move sodium and potassium across the cell membranes, which restores the electrical balance of the cells.
Which does what exactly?
This accelerates their metabolism.
Hmm?
It gently warms the tissue to improve fascial glide,
Meaning?
meaning The layers of tissue that were glued together by dense adhesions can actually slide over each other naturally again.
It remodels the matrix without the trauma.
Exactly.
So now the blood is flowing, the collagen is remodeling, but what about the immediate agonizing mucosal dryness that makes the scar feel like sandpaper?
For that intense focal point of dryness, specialists use hyaluronic acid injections.
We hear about hyaluronic acid in skincare all the time, right?
We do, it's everywhere.
But how does it function inside a pelvic scar?
It acts as a highly concentrated biological cushion. Hyaluronic acid has an incredible capacity to bind and retain massive amounts of water.
Okay.
So, injecting it directly into the focal point instantly rehydrates that specific microenvironment.
It gives the tissue its bounce back.
It really does.
It decreases the mechanical tension, so when the tissue stretches during movement or intercourse, it doesn't violently pull on those trapped nerve endings.
And beyond the injections and frequencies, the physical manual interventions are just as vital.
Right, the hands-on approach.
Perineal scar massage, usually guided by a specialized pelvic floor physiotherapist, is the cornerstone of this rehabilitation.
I always pictured scar massage as just, rubbing the area,
Yeah.
but it's actually a highly targeted physical mobilization, isn't it?
It relies on mechanotransduction.
Mechanotransduction.
Yeah, it's how physical force changes cellular behavior. The targeted manual pressure increases the local temperature just enough to make the tissue pliable. And more importantly, it physically forces those crossed over, tangled collagen fibers to stretch and realign into a more functional, organized matrix.
And it desensitizes the nervous system.
Yes.
Because if those parietal somatic nerves are hyperreactive because they've been trapped and sending panic signals for years, graded, careful massage helps calm that loop down.
Exactly.
It essentially teaches the brain that pressure in that specific area doesn't have to equal tissue damage.
If we connect this to the bigger picture, what we are seeing is a profound paradigm shift in gynecological and pelvic care.
It's a huge shift.
We're moving away from the purely mechanical architectural view of the body, where you just cut out the bad part, and embracing a biological, ecological view.
Treating the whole environment.
Right. These therapies focus on altering the local environment to restore vasomotion, elasticity, and cellular health.
It's working with the body's microscopic infrastructure instead of dropping a bomb on it.
Very well put.
So what does this all mean for you listening right now? The most important takeaway from all these clinical guidelines and physio manuals is validation.
Pure validation.
If you or someone you love is suffering from intense, localized pain and dryness years after a childbirth tear, you are not imagining it.
It is not a psychological failing, it is not in your head, and it is certainly not simply getting older.
It is a mechanical and circulatory reality. It is driven by damaged microvessels, chaotic collagen, and systemic hormonal shifts.
Absolutely.
And more importantly, a painful, dry scar is not a permanent life sentence. There are specialized professionals who deeply understand the microscopic mechanics of your pain.
Seeking out a pelvic floor physiotherapist or a specialist in regenerative gynecology can be the vital first step in restoring that microcirculation safely.
Before we sign off, I want to leave you with one final, incredibly bizarre twist from the clinical data that we haven't even touched on yet.
Oh, this one is wild.
Just when you think a scar is just a scar, the body throws a massive curveball perineal endometriosis.
It's a rare but absolutely remarkable phenomenon.
Imagine this. During a vaginal delivery, microscopic bits of endometrial tissue, so the lining of the uterus, are accidentally transplanted into the fresh episiotomy wound.
Just drop right in there.
Yeah. The wound heals over, trapping those cells inside. Years later, a hard nodule forms inside the perineal scar.
And because it is genuine endometrial tissue, it continues to respond to the body's hormonal cycles.
It actually swells and causes intense cyclic pain, perfectly synchronized with the woman's menstrual cycle.
It's literally bleeding inside the scar every single month.
It is a completely different mind-bending way a scar can haunt you.
It perfectly illustrates how incredibly complex, dynamic, and reactive these seemingly quiet areas of the body truly are.
Absolutely. Thank you so much for joining us on this deep dive. We started by picturing healing as a neat architectural process, but the reality is a delicate living city grid.
A very delicate grid.
And when a mitral pipe gets cut, you can't just pave over it with a laser or a scalpel and expect the neighborhood to survive. You have to get down into the microscopic trenches and restore the flow. Keep questioning, keep exploring, and we'll see you next time.